I'm Dr. Christopher Parker, and welcome back to Holding Space. If you are here for the first time, then welcome to Holding Space. But if you like and want to continue seeing these videos, like and subscribe, leave comments, and ask questions. There's an email. You can always email me with questions if you don't want to leave any comments. But I thought I would spend a moment talking about one of the comments that I've gotten, are actually, there have been a few that have sort of dovetailed together. One is based on diagnosis, and I think that one largely came out of the episode that we did on bipolar disorder and how it exists sort of on a spectrum. The point I was trying to make with that is that bipolar disorder can mimic some other disorders. Borderline personality disorder, as someone mentioned, yes, that definitely is one. But whereas borderline personality disorder is more characterized by instability of relationships and impulsive behavior, bipolar disorder is more characterized by unstable moods. And sometimes vast mood swings, sometimes what seems like just unstable moods from moment to moment. It really depends on the type of bipolar disorder you have. We haven't even discussed childhood onset bipolar disorder, but that will be for another time. I am a clinical psychologist with the state of New Jersey, licensed. I have been working in this capacity for over 20 years, and I have seen a variety of different disorders. Before that, I worked in New York. I have worked in a couple of hospitals. I've worked in universities, mental health centers, just about every place you can mention. So while I am by no means the leading expert on anything, I think my experience does give me some ability to discuss these matters. You are free, of course, to disagree. And please do, because it makes for an interesting dialogue and conversation. I think that the way we talk about diagnosis sometimes is upsetting to people, and especially people who don't agree with things they've been diagnosed with. And this is most particularly true for bipolar disorder. It's been called one of the most overdiagnosed disorders. And I have a tendency to think maybe that's true. People mistake the instability of mood, as I mentioned, borderline personality disorder, major depressive disorder, which is a unipolar sort of thing. Instead of achieving the highs, you just spend all your time in the lows. But coming out of that, and some of the early symptoms of major depressive disorder can be irritability, anger. It can sort of mimic some of the symptoms of bipolar disorder. Attention deficit hyperactivity disorder, ADHD, can be seen as possibly being bipolar disorder because of the disorganization and the tendency to be seen as dysregulated. And we really should do a whole episode on that, so we will. But there is a mood dysregulation that occurs with bipolar disorder. There's a mood dysregulation that occurs with ADHD. It's called rejection sensitive dysphoria. And yeah, we'll get to that. But the reason we have diagnoses, there's really only two reasons. One is that if you're using insurance to pay for sessions with the therapist or a psychologist, counselor, they need to give a diagnosis because the insurance industry works on diagnoses and what they will cover and what they will not. And diagnosis, also the type of session. It's complicated, and I really don't want to have to explain it all because it's a bit depressing, actually. We have a tendency to see people as people, first and foremost, But a diagnosis can inform us as to some things that we can expect. So if one therapist calls me and says, hey, I'm seeing this person and I'd like you to see them, they have bipolar disorder, of course, I will take that into account, but it'll give me some idea of what I might be able to expect. But I will not assume that that person was absolutely correct, even if I very much respect you and your opinions. Sorry to anybody who may be referring people to me. I, it's not that I disrespect you. It's that I have to make my own opinion. I have to examine the whole person, their whole life, and see what is going on with them. And at that point, even if there is a diagnosis that I can apply, I do not see the person as that diagnosis. They are not a bipolar. They are not a borderline personality disorder. They are a person with a particular set of symptoms. And as I've mentioned before, you can have some of the symptoms of a disorder and not all of them. In fact, it's rare that you find anyone who is like a perfect textbook example of a particular disordered pattern of behaviors. We don't routinely treat people as diagnoses. And there is the feeling too that you are being labeled for life as though there is some sort of permanent record that, everybody has access to, and it's sort of a scarlet letter that you wear. It's not. And thanks to HIPAA, which is mercifully still around, your records are private. Your diagnosis is private. The only people who know information about your therapy are people that you have signed a release for and allow. And that release should be specific about how long it lasts. It should be specific about who it's going to. We do not routinely release records to just anybody. We do not do a to whom it may concern. I don't anyway. I've never seen one that's to whom it may concern. Sometimes if you want to release some information to someone, I will address it to you and you can release it to whoever you want it to. But in that case, it's still private. There's no label that, and even then, I don't often tell what a person's diagnosis is. I will talk about the behaviors, or I will talk about what they need. So if someone has attention deficit hyperactivity disorder, I might mention that to a school if I'm helping them with an IEP or a 504 plan for education, simply because it gives an idea of what they can expect from a person. And also, I want this to be verified. There is a clinical way of verifying it. There are instruments for verifying this. And it gives them a full picture of the types of behaviors and needs that they might see. This should all be done for your greater good. This is not done to hurt you. I can see how it would be determined that way, especially if it's a diagnosis that you don't agree with. But I will frequently have people who will come to see me who will say things like, oh, I have borderline personality disorder. Well, who told you that? And a couple of years ago, and it may still be the thing, there was sort of a trend for people to believe that they had dissociative identity disorder or multiple personalities. That I actually have not seen a case of DID in person, and that's despite all the places that I've worked. And I mean, I could work with it if I saw it, but I have not seen it. It's rare, and if it exists at all, I hate to say that, but once you have been doing this for this many years and you don't see something like that, you begin to become skeptical. It's a rather severe condition, and I'd like to think that there aren't that many people walking around suffering with this because it would cause some suffering. Um, Schizoaffective disorder is another condition that involving mood episodes with psychotic features similar to bipolar disorder. And some bipolar disorder individuals will manifest psychotic symptoms. They will have beliefs about things that are not patently true or observable by other people. Frequently, these are about things that are someone is after them or something is being mishandled. And once your head gets an idea about something, once you have formed an idea and an opinion, it's pretty hard to erase it, even if you come to realize that you've had a disorder that's caused you to think this way. Schizoaffective disorder is less agreeable to treatment. It usually requires more extreme medications. Bipolar disorder usually does require medication in order to achieve stability. I'm not a big fan of medication, but I am a big fan of people feeling better and being able to handle their lives in the best way possible. And usually with bipolar disorder, that does involve medication. All this is sort of like a long roundabout way of addressing the idea that we need diagnoses for certain reasons. We need them to convey information. We need them to get insurance coverage. But I do not see a person primarily through the filter of that diagnosis. They are fully rounded. They have full lives. They have families frequently. They have careers. They have things that they've done. They have things that they've accomplished. They have some successes, some failures, like the rest of us. First and foremost, you are a human being when you walk into my office, and just about any other therapist that I know and respect. If you have doubts about that, ask. It is better to have everything out on the table and be out in the open. Talk about your concerns. Talk about your fears. And see if the therapist can help you with those, if they can make them go away. If they can't, then you can look for a different therapist. That's totally okay. It is fine to say, I just don't think this is going to work with us, so I'm going to look for somebody else. It is your life. You wouldn't buy food that tasted bad. You shouldn't go for therapy that feels bad. So this is a long roundabout way, once again, of saying a few things, but mostly diagnosis. And a lot of it has to do with the subtlety of some of the disorders that we see. I do work for Discovery Psychotherapy Center in Cedar Knolls. Used to be in Morristown for years. If anybody's in the neighborhood, feel free to drop by and say hello. But we, myself and some of the other therapists that I work with are going to be joining me on some of these podcasts. So you'll be seeing more of us. If you have questions, comments, things you want us to discuss, please feel free. Ask. And we are holding space for you. Thank you for tuning in today, and I will see you next time.